Hello and welcome. This is Neil Dilworth. Today we're going to be reviewing elbow conditions that affect the athlete, a comprehensive review of various conditions affecting different anatomical regions around the elbow. These are the conditions that we will be covering. Nice thing with the lecture is that you can go back at any point to review either a list or a subject if we're going too fast. But we're going to carry on. Essentially, it's in the order as presented under this condition slide. A couple things to keep in mind when we're talking about either assessing the elbow or treating the elbow. Anytime you're assessing an athlete's elbow, it's very important in that assessment that you include range of motion, both active and passive, to include extension, flexion, pronation, and supination to make sure that you're not missing any loss of range of motion. Snapping, plunking, or locking, and as well as a neurovascular examination because the neurovascular structures, both the arteries, the ulnar, radial, and median nerve are quite superficial. They can often get injured along with some of the more superficial tissues. Also, note that when recommending elbow mobilization, the elbow is one of the joints in the body that is much more susceptible to stiffening than other joints. So if you're going to recommend a mobilization in a sling or in a splint, make sure that you also recommend a follow-up and a specific time for removal and mobilization. Ideally, the shorter amount of time, less than 3 weeks, would be ideal. However, given what the underlying condition may be, it may require further mobilization. And then the other consideration is just with respect to some baseline anatomy, more specifically along the lines of the pediatric elbow and looking and assessing for the x-rays. This is just a reminder of the various ossification centers around the elbow. First one that spots up is the lateral aspect of the trochlea, which involves the capitellum, and then you'll have the medial aspect of the trochlea, which is just the trochlea. The next one was actually the radial head, followed by the medial epicondyle, followed by the trochlea then, and then the olecranon, and then the lateral epicondyle, which is E for external. One of the things in kids with Comm's fracture, which we'll discuss later, there's a couple of things you're looking for in occult fractures of the elbow. One is a sail sign, which you'll see as a black sail coming at the front of the elbow. Sometimes you'll see a posterior sail as well, which is essentially two fosses, one at the front of the elbow or the anterior surface, and one posterior. And there's fat pads in both those areas, which can get displaced on the anterior aspect anteriorly or the posterior aspect posteriorly, and cause a radiolucency to show up in the shape of a triangle or a sail. Second thing to take a look at is what we see here is this anterior humeral line, and that should transect the midline of the capitellum. If there's something along the lines of a supracondylar fracture, that'll often be displaced, and sometimes this line can go right down along the anterior aspect of the capitellum, which is an indication, obviously, of fracture. There'd generally be an anterior sail sign as well in that situation. First off, we're going to start with one of the commonest conditions that's going to be seen in primary care practice, which is lateral epicondylitis. Most typically it occurs in the middle age or master's athlete. Typically with overuse, it can occur after acute injury and be associated with partial tear. You can also see it in a non-athletic population. There's association with certain rheumatological conditions and diabetes as well. Also known as tennis elbow, essentially it's a tendinitis or enthesopathy of the extensor carpi tendons, where they originate off the lateral epicondyle, and the pathology is referred to as angiofibroblastic tendinosis. The differential diagnosis of the lateral epicondylitis is very important, and this is a common condition, but what you don't want to miss are things like radial tunnel syndrome, radiocapitellar osteoarthritis, radial head fracture, an osteochondral defect, or referred pain. The other one would be a synovial plica, can also cause this condition. On examination, they're typically tender over the lateral epicondyle and have pain with activation versus resistance of the extensors. If not with the elbow inflection, most likely will have pain when you bring their elbow into extension and extend against resistance. Imaging is mostly clinical diagnosis. However, if you're concerned about something else, like for example a complete tear or a great partial tear of the extensor tendons, you can consider ultrasound. X-ray if you're concerned about an underlying osteoarthritis or a osteochondral defect, or MRI if you're concerned about an osteochondral defect and the X-ray is negative. The management of lateral epicondylitis essentially is a condition that can last well up to 18 months and beyond. There's a number of treatments that have been recommended. Physiotherapy and eccentric strengthening stretches, as well as elbow strap, are among the commoner recommendations from a conservative perspective, and show some benefit. Topical nitroglycerin is another option, as well as needle tenotomy, acupuncture. Cortisone injections, mixed results from an evidence perspective, but still offered as a treatment commonly. Activity modification, and then if resistant to conservative treatments, surgical tenotomy could be considered. Medial epicondylitis, or also known as golfer's elbow, is the next condition we'll cover. Essentially, it's the opposite side of the elbow, on the inside of the elbow over the medial epicondyle. This is a tendinitis or tendinopathy or enthesopathy of the flexor carpi tendons. We'll correct that for the talk. The pathology, once again, is an angiofibroblastic tendinosis. Typically, overuse can occur after an acute injury or associated with a partial tear, but once again, it can also happen in the absence of activity, usually with some underlying medical condition. Differential diagnoses include medial epicondyle apophysitis in the pediatric population, ulnar collateral ligament injuries, ulnar nerve subluxation, osteochondral defects, and referred pain. On examination, once again, you're going to tender over the medial epicondyle, pain with activation versus resistance, both in flexion and extension of the elbow. Imaging, once again, this is a clinical diagnosis. If you're concerned about some underlying ligamentous injury, you consider ultrasound or MRI, or joint issues such as osteochondral defect, you consider X-ray to start. Once again, the management is similar to lateral epicondylitis. There's less evidence with respect to treatments for medial epicondylitis, as it is not as common as lateral epicondylitis. It can include similar treatments to lateral epicondylitis. Biceps tendinitis. So this tendinitis, biceps tendinitis, insertion of the radial tubercle. Biceps actually more important as a supinator, and this is something that can happen as a result of the degenerative tendinopathy. It tends to happen in the 40s and 50s for patients in their 40s and 50s, can happen in secondary overuse or secondary to an acute eccentric load, similar to like a partial tear of the biceps distal tendon. Differential diagnosis includes radial head fracture, elbow osteoarthritis, osteochondral injury, biceps tendon partial tear, ulnar stress fracture, supinator tendinitis, and radial tunnel syndrome. On examination, the patient should be tender over the biceps tendon and insertion of the radial tubercle, pain with supination, and they may or may not have pain with resisted elbow flexion, as the brachialis, which lies deep to the biceps, is a stronger flexor. Also, they should have a negative hook test. So essentially, you hook your finger over the tendon superficially and try and pull it to the side, and that should be intact. Imaging, you can arrange for an ultrasound, or if not convinced or concerned about other pathology, you can consider an MRI. Management is typically conservative with physiotherapy, stretches, and eccentric strengthening. One case series of only 4 patients described the use of a splint immobilization initially for about 1 to 2 weeks prior to the physiotherapy. Distal biceps rupture. So the biceps tendon fully tears, either tendinous or sometimes with an avulsion from the radial tubercle. It can be associated with anabolic steroid use. You can see the picture above, full biceps here on the left, and on the right. Looks like the biceps bigger, but actually if you look at the distance between the elbow and the distal bicep muscle bulk, it's actually lengthened. and that's because essentially it's torn completely. The patient had a positive hook test. This is the opposite of what we were talking about before. So the difference between a biceps tendinitis and a distal biceps rupture is that you'll be able to displace that tendon completely. There's typically swelling and bruising to the anterior arm and forearm, and pain with palpation of the anterior elbow and weak supination. There's also proximal migration of the muscle, which is called a positive Popeye sign, which you can see on the right biceps on the left of the image. Above imaging, you can do an X-ray to look for a radial tuber osteovulsion, ultrasound to confirm the biceps proximal migration, or even an MRI for surgical planning. Management involves immobilization of sling. Conservative can result in reduction in supination. Often with the younger patients, they will opt for surgical repair. And just to keep in mind, there's a risk of radial nerve injury with that. Triceps rupture. So triceps tendon fully tears either tendinous or with an avulsion. As you can see on the image on the right of a left elbow, a triceps avulsion, you can see that there is a olecranon fragment that is quite proximal to the elbow. The differential diagnosis here, typically that's due to an eccentric load. So essentially, patient lifting a heavy weight over their head, and essentially as the elbow is being pulled in flexion, they try and extend at the same time, and either the olecranon gets avulsed or the tendon, intertendon gets torn. Differential diagnosis here is a triceps tendinitis, partial tear, an olecranon fracture in isolation in the absence of a triceps tear, and olecranon bursitis. On examination, there's typically swelling, bruising to the posterior arm, pain with palpation of posterior elbow and arm, and weak when extending the elbow versus resistance. Imaging, once again, we want to do an X-ray to take a look at the fracture, an ultrasound MRI to assess for the amount of retraction of that fragment, if present, and also any kind of associated injury. For example, acute dislocation or subluxation, which after reduced may demonstrate some ligamentous injuries. Management would include mobilization initially, trying to mobilize the patient and as much extension as possible that the patient can comfortably tolerate, and refer for an orthopedic surgical opinion for surgical repair. Conservative treatment is possible, however, very likely to result in extension weakness. So once again, most of our younger athletes will be referred for surgical referral. Snapping triceps syndrome. So this is a snapping condition of the triceps tendon over the posterior and medial elbow, and it can be associated with ulnar nerve subluxation. You can see the proximity of the ulnar nerve to the triceps tendon here, and affects weight resistance training. So people doing weightlifting, going to the gym quite a bit. The triceps tendon is wide but thin, and this is the contributing factor for why it has a tendency to snap over this medial epicondyle. And it can be difficult to distinguish between this and a subluxing ulnar nerve. A cubital tunnel syndrome, which is compression of the ulnar nerve at the various positions around the medial elbow, and plica syndrome. Patients are able to recreate snapping with active extension of the elbow from flexion, and this can be confirmed with dynamic ultrasound, which will show the triceps snapping over the medial epicondyle. Management is typically conservative with physiotherapy or chiropractic treatment, looking at ART, Graston, rolling the triceps, avoiding hyperextension of the elbow, and then physiotherapy or personal trainer to adjust some training techniques. And if it's still persisting, considering surgical referral. Radial tunnel syndrome. Radial tunnel syndrome refers to the impingement of the posterior interosseous nerve of the radial nerve. So the radial nerve comes down the lateral arm, anterior to the humerus, and the posterior interosseous nerve branch actually goes deep to the supinator. And typically what ends up happening is patients, usually women greater than men, between the ages of 30 and 50, repetitive essentially rotation of the elbow, and what ends up happening is there's compression of the posterior interosseous nerve due to the overuse of the supinator muscle. The differential diagnosis here is because of the lateral elbow, lateral epicondylitis, radial capitellar osteoarthritis, radial head fracture, osteochondral defects, and referred pain. On examination, this is the key. So it can be very difficult to differentiate these patients from just lateral epicondylitis. About 5% of people with lateral epicondylitis are believed to actually have this condition. So what you want to do is you have the patient flex their elbow and fully pronate their wrist, and when they go to extend their fingers on the affected side, there will be weakness. The second one is that when you're providing resistance against supination, that they will feel pain. And the third one is that when you palpate the supinator muscle, it'll be tender to examination. In terms of imaging, this is a clinical diagnosis. Imaging is not overly helpful in diagnosing radial tunnel syndrome, as X-ray, ultrasound, MRI tend to be normal, as do EMG and nerve conduction studies. Sometimes a diagnostic local injection to the radial tunnel, which is that area that goes underneath the supinator here, can be helpful from a diagnosis perspective because you can retest them and that weakness should go away. In terms of management, you're actually looking at immobilizing the wrist because that's where most of the action that activates the muscles involved occurs, and then avoiding any kind of prolonged extension of the elbow and pronation of the wrist, and then the other one is avoiding wrist flexion. And other things can be considered in this condition are anti-inflammatories, physiotherapy to work on both supinator stretching, deep tissue work, and stretching, as well as consideration for a cortisone injection, and if conservative drug fails, considering referral for surgical decompression. Osteochondritis dissecans of the capitellum. So this is an injury involving the cartilage plus or minus bone of the lateral radial aspect of the elbow or capitellum. Occurs in pitches or overhead athletes, tennis, ping pong, gymnastics, quarterbacks in football. The mechanism of injury is essentially a repetitive valgus stress on the elbow, which is associated typically with ulnar or medial collateral ligament injuries. The differential diagnosis includes lateral epicondylitis, radial head fracture, radial tunnel syndrome, lateral elbow osteoarthritis, and extensor tendon strain tear, as well as supinator strain or tear. On examination, there's a loss of range of motion. There is an effusion with both posterior and anterior capitellar pain. Imaging, an X-ray sometimes can be helpful. As you take a look above, you can see radial lucency present on the lateral aspect in the capitellum. The MRI of this patient demonstrated a capitellar osteochondral defect. In terms of management, the key here is essentially rest and protection. If there's an ulnar collateral ligament tear and there are overhead athlete, you may consider referral for surgical reconstruction. Physiotherapy should focus on the flexor strengthening and pronator strengthening, as well as range of motion and bracing, and essentially not to return to either loading the elbow in terms of gymnastics axially or throwing until both asymptomatic and cleared from primary care or surgical provider. Little league elbow, also known as medial epicondyle apophysitis of the elbow, common in throwing sports, especially baseball, and affects children. Typically, it's an overuse injury can occur after acute injury, such as a single pitch or associated with partial tear of the ulnar collateral ligament. It's essentially the same as a valgus overload, but in a younger patient with an open growth plate. The differential diagnosis includes an ulnar collateral ligament injury, ulnar nerve subluxation, osteochondrial defect or osteochondritis dissecans, avulsion of the medial epicondyle, and referred pain. On examination, they're typically tender over that medial epicondyle, and there's pain with activation versus resistance when testing the flexors, and pain with valgus stress to the elbow. Imaging clinically, it's a clinical diagnosis, but you can also consider an X-ray to make sure that the medial epicondyle is not overly avulsed. Ultrasound to assess the ulnar collateral ligament, or MRI, to take a look to see if there's any other ligamentous injury or osteochondral defect. Management essentially is considering immobilization for the first 1 to 2 weeks. If they're non-tender and they've progressed well, they may start throwing at 6 to 8 weeks. Typically recommend 2 weeks of non-tender medial epicondyle before initiating a throwing regime, and then it's a gradual progression back up to full. For non-union medial epicondyle cases, which are not progressing, so typically still tender at around the 6-week mark, consider MRI or MRA and ortho referral for an open reduction internal fixation of the medial epicondyle. Ulnar collateral ligament injuries. These are either sprains, partial tears, or complete ruptures of the ulnar or medial collateral ligament of the elbow, and they can involve one or more of the bundles. Long-term, these injuries can lead to chronic valgus overload and radiocapitellar osteoarthritis and osteochondral defects. The mechanism of injury is typically a valgus overload or an acute valgus stress. More commonly, it's a repetitive valgus stress, such as throwing or overhead sports. The differential diagnosis of medial epicondylitis, medial epicondyal apophysitis in kids, avulsion fracture, bone contusion, or osteochondral defect. On examination, there is typically a little bit of swelling, could be bruising if it's acute, and it's most likely tender over the medial elbow. There is laxity with a milking test for valgus stress at 30 degrees of flexion of the elbow, as well as pain in the medial elbow. Imaging X-ray usually helpful to rule out avulsion or radiocapitellar osteochondral injuries, and an ultrasound can be useful in assessing the ligament as it's quite superficial. MRI or MRA, if suspicious of an osteochondral defect, can be also helpful. Management: these partial tears are typically treated conservatively, and the rehab's geared at range of motion, flexor, pronator strengthening, as well as throwing mechanics, even looking at both the shoulder and neck as well. PRP may be considered for partial tears, and bracing consideration for the initial phase of rehab as well. With respect to complete tears in overhead athletes wishing to return to pitching or throwing, a consideration for reconstruction or Tommy John surgery would be ideal. Elbow dislocation. So majority of elbow dislocations are posterior dislocations. They account for over 80%. In terms of mechanisms of injury, they talk about 3 stages. The first stage involves the lateral collateral ligament complex. This is where the nomenclature can get a little bit confusing. Part of that lateral collateral ligament complex is the lateral ulnar collateral ligament. This is not to be confused with the ulnar collateral ligament on the medial side of the elbow. This ligament acts almost as a sling from the humerus around the radial head to the ulna, and when this essentially gets torn, it leads to posterolateral rotatory subluxation of the elbow. Actually, we'll see that slide shortly, and it'll make a little bit more sense. Stage 2, the anterior posterior capsule tears, and essentially the elbow is beginning to dislocate. It's just that the coronoid is still catching on the anterior trochlea. And then the final stage, the ulnar collateral ligament or medial collateral ligament on the inside of the elbow tears or ruptures, and then this is when the olecranon dislocates posteriorly. The differential diagnosis includes snapping triceps, ulnar nerve subluxation, posterolateral rotatory instability, and osteochondral defects. On examination, there's typically a large effusion. The athlete will want to protect their arm and hold it in position. There's essentially global joint tenderness, and there's usually a deformity as well. Imaging, X-ray, MRI for ligamentous injuries. This can happen after obviously the acute treatment, which is essentially to reduce the arm. The other associated injury is obviously there's typically a tear. There can be a tear of the flexor origin as well involved with this dislocations, and then obviously the other one would be fractures associated with elbow dislocation, whether it's coronoid, olecranon, or humeral fractures. Management is essentially to reduce with supination of the forearm, followed by axial traction and flexion then of the elbow, and then once it's reduced, immobilization, orthopedic referral, obviously with neurovascular assessment. Consider a bi-hinge brace in the acute phase of recovery for protection. And generally speaking, we're looking at about 3 to 4 weeks minimum for that. Posterior impingement or valgus